like to invite Sachin. Sachin has been running a practice for the last 4 years, which is diabetes and obesity, cash pay. And I know that you have some online questions, and we can all share collective wisdom. I know there are a lot of people here already practicing. Any other questions? I know that you want to start a practice.
Yes.
Right? So
tell me how to do it.
So sorry, you said they pay before they come in to see you?
yes, you can decide, because then, for example, when you checked into the hotel, they took a charge from you for your room, right? So those mechanisms exist for you to collect upfront for your services, right? So if you're in a cash pay business, how do you do it?
Yeah. So just to give you a quick background of our practice, so we are an independent practice in California. So our position is a triple board certified physician, family medicine, diabetes, and obesity. And over the years, as we started treating a lot of diabetes patients, we realized how much obesity plays a role in actually helping them manage some of those comorbidities. So we decided to start like 5 years ago, start an obesity practice. But in the sense that we just wanted to have a specialized track for patients who are on diabetes to help them lose weight, the combination of medication, other aspects of it. Unfortunately, what we realized is that some of the services on the obesity side were not being reimbursed by the insurance. And so we ended up changing the plan and the way we were operating it. So we said, we're going to make this cash flow. Just the obesity part of it. And we were clear to the patients that we want to do a lot more for you on the obesity side. But unfortunately, this is the way it is right now. Are you open to paying cash? They're okay with it. So that's how we started 5 years ago. And we keep kind of going back to how we're charging patients, because we are in a semi-cut underserved area. A lot of patients are on Medicaid. Some patients who are actually on fixed income, some of them are not able to afford. So we made it affordable. So just to give you an idea, we started off giving new patient appointments at like $150, and then the follow-ups at like $50 or something like that, just to make it more affordable for them. And what has worked for us is that we were able to create a space where patients were able to work with us to talk through the motivation building aspects, work on their sleep and stress situations. So the physician was able to work closely with them and gave them very specific kind of a roadmap on how we start doing some of these things. And we started seeing a lot of positive results. Now, over the last 2 or 3 years, we realized that because we have to juggle like 2 types of appointments, primary care patients, diabetes patients, and patients by the same provider, it was getting harder to kind of juggle that both from front office as well as the physician himself. So we decided to switch it and say, we're going to do all of the obesity appointments over the weekend, like Saturdays, and Saturdays. And then we also realized that patients are not keeping up with the appointments. And when we have smaller set of appointments available, it becomes harder when you have no shows, for no reason, right? So we decided that for new patients, when we want to make an appointment, we are asking for an advance. Say, we're going to ask you to pay 50% off, because we want to be mindful of other patients who are still waiting for us. So please make sure to show up, otherwise we forfeit the 50% of the fee. And we thought, I don't know how many people would like it, or some of them said, no, that's too much, I'm not going to make it, which is fine. But I think over the last year or so, we've started to realize that, I think the panelists pretty much confirmed that, is once you commit to it, there's a better chance of actually keeping appointments. So it's working out great. And we have yet not started charge follow-up appointments yet as an advance fee, but we did increase the cost of the follow-up appointments because we started to spend more time for the patients on aspects of the obesity side. So hope that answers the question.
How long are your visits?
I'm sorry?
How long are
How
the
long?
visits?
So our new appointments typically last around 45 minutes, and our follow-ups are between 25 minutes.
And the frequency?
So all appointments are a 1-month follow-up, and we do dispense, especially if patients are getting any of the controlled substances, we do mandate it to be 1-month follow-ups.
And many of you might think that, what are we doing here? We are actually, I'm a gastroenterologist in practice, and we're launching a platform which is a complete digital ecosystem to take care of your patients in a complete way. So all the solutions that you are hearing, that you need marketing, you need a website, you need an EHR, you need communication, you need payment collection, you need RPM for ancillary revenue, you need dietitians for ancillary revenue. You do that all within one platform. So that's what we're launching, and FusionCare's first practice is in Sachin's practice in California, which is up and running and profitable. These are just solutions I think that will come down the pipe, and a lot of questions are about cash pay, but I'm sure they will also move into insurance based, because not every demographic or neighborhood will be able to support that. But to answer your question, to start a practice, you will need just one solution. You start and you practice the way you want to by using the services you want to give them. Okay. There are two questions online which I'll take. One is from a psychiatrist who wants to open an obesity practice and is wondering whether he can do that. I don't see any problem doing both at the same time.
No, I don't. So I think the industry is kind of tricky in terms of regulations that we have. There is covenants where certain licenses that you get, you're restricted to offering only certain services or billing certain services, because you have a taxonomy that the medical industry recognizes. But the challenge that we see is that we have almost over 40% of the American population either obese or overweight. And unfortunately, we don't have enough of the access in terms of enough providers who are actually prioritizing or focusing on obesity medicine. And it's not just about writing prescriptions, it's about understanding and actually addressing all aspects of obesity, right? So the good news is that there's an opportunity for every specialist, including primary care physicians, to be in that space. And they're already doing it to a certain degree. And by coming to conferences like these, PCPs, even our nurse practitioners, are able to gain that experience to actually prescribe. So there's no restriction in terms of that license of what you prescribe, especially anti-obesity medications. So I don't think there will be an issue in terms of starting. The only tricky part you have to understand is that if you have an entity that you've contracted with insurances, and the insurances are providing support or reimbursing services related to obesity, like an obesity counseling service or even some other services, you have to be careful about charging the patient on a cash basis. That violates the contract that you have with insurance. You have to be careful about that. Another example is with Medicare. Medicare also provides some support, not a lot of support for obesity, definitely no restrictions. They don't pay for any of that Part B or Part D. So the challenge with Medicare is that because you're both as an independent physician as well as a group entity, you're always contracted with Medicare, you have to be watchful about charging in cash for Medicare patients. So there are cases, even in our case, we are very clear for patients who come into cash-based practice. We tell them that first, we are not able to offer you service here on cash-based. We can do in our primary care setting some counseling to you, but we cannot provide you full obesity treatment because we have to charge cash for that.
Could you, I'm sorry, I missed, forgive me. You can't see Medicare patients in your obesity practice, but you can see them in the primary practice.
In a cash-based obesity practice, no. Yeah, especially if you're providing services that are covered by Medicare.
Could you repeat the question?
Oh, sure. Yeah. So the question was, can you see your patients in a regular obesity practice for counseling related to obesity, but not see them in a cash-based practice?
Could you repeat that question?
Oh, okay. So the question was, can you see the Medicare patients in a cash-based practice? The answer is that you have to see them only in your contracted primary care business service aspect, because you're contracted with Medicare under that. The only things you can charge patients is services that are not covered by Medicare. You can then charge the patient, but there is something called ABM, a document that you have to have the patient sign, where the patient says that, I understand that Services such as these are not covered by Medicare, and this physician will have the option to bill you on a cash based. Yes.
You could opt out at the end of your 2-year agreement to not do Medicare, correct? And then you could do cash for your Medicare, right?
Yes, and it's a little tricky what is complicated with Medicare, but yes. The thing with Medicare is you either are in or out, which means that you literally have to sign on or get yourself out of it, and there is a 2-year waiting period before you go back into Medicare. So that's right. Leo.
Sachin, I think we spoke earlier in regards to having, like I work in the Indiana side, but I live in Chicago, and I'd like to open a Chicago practice. And we spoke earlier about having 2 NPIs, where you said you can have like a primary or secondary. Can you elaborate on that a little bit further? So, because I do accept the Medicaid, Medicare in one practice, but in my other practice, I prefer not to. And you're saying that you could have like 2 versions of the NPI or like a subversion?
Yeah, the question is, what options do you have in terms of providing cash-based service while you're contracted or working in another setup under your employer base, for example, right? So typically, and I'll give our experience, but I just want to be clear that every state is different, every payer could be different, and how you deal with it. But typically, what happens is, as a provider, you obviously have an NPI that's an individual NPI. And then when you start practicing, you typically are creating an entity, and you can create what's called a type 2 NPI. That type 2 NPI allows you to, it's like a group NPI, which means that it allows you to hire other practitioners or providers into your practice, and you can bill under that. And then all of your will be billing under that group NPI. And if you have contracts with insurance payers, typically that will be your type 2 NPI. So what happens is that if you are working as in that group, even in this case, if you are employed by an FQHC, you are working under FQHC and they are billing under type 2. That's an organization's NPI.
So you think the one I have is a type 2?
Yes, if you're employed by an FQHC.
But I had a different NPI prior to getting there. So you're saying right now I have 2 NPIs?
You do. Everybody has 2 NPIs, but your affiliation is with type 2 through your employer. It's not your individual, it's through your employer. So if you're employed with 4 different companies, for example, in the past 10 years, you can be sure that your billing history would show that you billed under 4 different NPIs. All are your employer NPIs.
So can I then open a practice and not accept insurance, not accept Medicare, and not have any issues with my employers?
Right. So the one way to look at it is, again, I'm not the attorney or I'm not the healthcare attorney specifically, but I'm just speaking from my experience, right? Yeah. So the way I would think about it is, if you're starting on your own, you already have an individual NPI. You can start practicing with your individual NPI, right? Prescriptions. The NPI really is used by payers to contract with you, right? Think about it as an SSN, right? In a way, you need to identify you. Now, the challenge there is that you're already contracted with Medicare under your individual NPI, as well as any type 2 NPI you had before. And that's the reason why you cannot charge Medicare patients with your individual NPI. That's why either you accept the patients, you can say, I'm going to do cash only for all patients, but if a Medicare patient walks in, you can either say, no, I don't see you, or I'm going to have to bill you Medicare and take whatever Medicare pays.
So I'm allowed to say no to them, that I just don't accept Medicare, period?
Yes.
I want to follow up on that because I talked to a compliance officer similar to the MPI. I was asking her if I needed a second MPI. So I'm an ER doctor. I'm enrolled with all the insurance companies in 10 different hospitals, but I wanted to do a cash practice. She said it's not a problem if it's in a separate location, that I don't need a separate MPI. As long as I'm seeing all of these people in a separate location, it's really more about where you're seeing. So I couldn't see them in the hospital for cash, but she kind of gave me the impression I could see them someplace else and charge cash, and it's not fraud.
So I'm not sure, but I can tell you why the way you would approach is that what they're saying is something. Okay, sorry.
Yeah, for the online use.
Right. So as an employed ER physician, your question is, can I be outside in a different location and have my own cash-based practice, right? So my answer to that is, based on my understanding, is that you will be practicing under your individual NPI. That's how you're able to do it, because your employer is actually billing another type of under the facility that you are employed at. There's a question online saying that will this be recorded? Yes, it's being recorded. This time
We get the recording.
Yes, it will be made available. Last time we had a technical glitch. You had a question in the back.
I was just wondering, as you mentioned, unlike other private insurances, Medicaid follows, right? Does it follow you across state lines, right?
Yes,
Federal,
Medicare follows you everywhere as long as the US, yes.
Both insurances and cash pays said you have to be careful when you charge patients, like for insurance, if they also cash based services. Does it need to be some sort of same pay, the same services, or what do you mean by that?
I think what he was alluding to. So the question is that can we charge differently for purely for cash pay, or if you're taking insurance?
Yeah.
So with insurance, your risk is only if you are charging for the covered services. So if an insurance already pays for something for which you are charging higher cash, that could be an issue for money. Is that correct? Yes.
So as long as you are contracted with an insurance and you are not allowed to. So the thing is, with a lot of cash practices, what you're telling your patients is that I'm going to charge you cash. However, I'm not contracted with that insurance. But if you would like to go and send the bill to your insurance, see if they reimburse you, you have the option. So you can ask the provider to give them a super bill that says, okay, my provider spent time on these services, and we can include the CPT codes, and they will take that bill as an individual and send it to the insurance. And you know, if the insurance has any services related to obesity care and they want to reimburse the patient, they could. But at this point, I want to say good luck to that, because a lot of payers just don't have. The only thing they have is preventive counseling for obesity.
But if you were to add, let's say the patient had a comorbid condition, hypertension, hyperlipidemia, metabolic syndrome, insulin resistance, and that is in your super bill. And those are not purely obesity codes. I believe that you'd be considered an out of network, and they would get some reimbursement for them.
Right. The question is, if there are comorbidities associated with obesity and you end up treating the patients, and then you end
Or
up
addressing them as comorbid conditions contributing to or in association with obesity, then the insurance has to see all those codes and say, well, they went to this doctor for an opinion, was out of network. They would pay something.
That's right. So there are payers who actually will pay you where the consumer back as an out-of-network provider. That's possible, yes. Unfortunately, the challenge with all of us here as providers is really that we're dealing with payers who have such different roots. Especially even if you think about Blue Cross being, standard across all states. Unfortunately, no, every state has a blue plan which treats differently and what they cover in the obesity. You had a question?
So I was at a talk yesterday, and the speaker made mention about clients being sued for having websites that were not ADA compliant. I had no idea that was a thing. Can you speak to that? Like, is that like something I really need to be concerned about? Do I need to find a web designer who has knowledge of ADA compliance on the website?
So the question is, what is this about websites being sued for being non-ADA compliant? It is true. ADA, American Disabilities
For
Act.
disability.
Yes, yes. So that's been there for a while, actually. It's nothing new. Some states are more vigorous. I mean, was it in California?
The practice was Colorado-based,
Yeah.
and the lawsuit was from an activist group in California.
Yes. So it is, it's a true thing, obviously. And yes, there are certain requirements from an ADA point of view in terms of how the information is presented. Especially one thing that I remember talking about is being mobile friendly and being able to read. I mean, you can't really make it, for example, braille friendly, right? I think But there are certain minimum requirements that ADA has. Typically, if you're hiring an agency to build your website, or most of these, what do you call WordPress or templates, the templates that you can buy are ADA compliant, but it's up to us to make sure that that's confirmed. Because as much as they make it easy for you, we're not looking at the fine print, but that's a great fact that we need to be conscious about doing that.
And I think we should be conscious of doing that, that we have, access to everybody to the content we have on our websites. And if we are just aware and when we are designing, we do it upfront. So, have a reasonable agency or credible companies like us to do it for you. But I would advise against doing it yourself. A lot of social media groups, I say, how are you adding this section? And so
actually, I have an example of that
yes.
as well. So one other thing that's required is nothing to do with ADA, but it's everything to do with every state's policy, even federal law. Actually, they want to have a what's called privacy and usage policy on your website, clearly stating the information you're collecting on the website, what is the purpose of that, and how are you going to use it. And it's very important to have. And the good thing is, a lot of the professional associations you work with, including a malpractice coverage that you get, they can provide you that template, and it actually tells you when you're. And most physicians' websites are pretty informational, but there are some that go beyond that to actually capture some information. And in fact, we're supposed to, even in California at least, not only on the website, you're supposed to have those printed and available in the lobby as well, to tell the patients when they walk in what information you're capturing, how do we use it, etc. So you got to be very careful, and you should always have that as another checklist item on the website.
Yes, Jordan.
So, is it fee for service the same if it's in person? And is it the same in person as it was telehealth or obesity medicine?
The coding and billing is very specific to how it's provided, the care is provided, what diagnosis codes have been billed, what insurance, and how much money you will collect. So all of it.
Right, sure. And if someone, let's say, okay, I am at my licensure in a state here, but I reside in Grand Cayman. Can I practice in that state? Practice telehealth remotely and out of the USA?
So the question is that she lives overseas and she wants to provide telehealth in a state or any state.
No, okay, so let's say Florida, because
So-
I know it is state dependent.
So you want to provide telehealth services in Florida while living in Grand Cayman.
And she is licensed in Florida?
Yes.
In Florida.
Yeah. I believe that as long as the patient is in Florida, you're licensed in Florida, the law requires that you are licensed and the patient is in that state, that you should be okay. I believe that because I practice in 10 states, I am not in 10 states. The patients are in the respective states that I am in, and I see them. Now, I believe that I cannot see a patient here sitting, a patient in Spain, because I don't have license to practice medicine in Spain, but I've seen patients while being in Spain, patients in America in their respective states. And that is something that has been provided, which should be okay. So I know a lot of physicians who practice out of the country, but provide for the care of the licenses they still actively have in their states, and they can be. There's no law telling you you cannot be out of the country.
Right, so there's a telehealth vendor here, Moxie, what? Oh, I don't remember. the name.
Okay, let's not take names.
Oh, right,
Yeah.
and they told me pretty much the same thing, and
Yep.
I subsequently checked it, and as far my understanding is, that is correct.
Yep.
Because, right,
So we have a physician here who has a license in 10 states, but he lives in one. I mean, he cannot live in tent. And he provides care and it's legal. And for that reason, what you're suggesting is also possible, yes. That's how direct to consumer telehealth platforms hire physicians on contractual basis.
We just know it keeps
All the rule states that are just saying, so certain states you license their, you actually have to provide them services while starting in that state. So like Vermont, so for one, so Arizona, yeah, when I'm outside of the state.
What state do you practice in?
In my office.
Vermont? Yeah, so this is a healthcare provider here who so there are state-specific rules, and maybe that's why these telehealth companies actually will tell you that we are in 44 states, not all, because the state-specific rules might not allow you to be not physically present in that state. Do you have a state license in Vermont?
No.
No. So so that's why best thing, Joel, is to check with the local
Yes.
medical.
So
All
actually, if you look for telehealth, it pulls up the requirements of all the states listed alphabetically and the requirements. Can you do it? Can you not do it?
Wait, what is it?
If
So she's saying that
Yes.
there's a place where all these statewide regulations are listed on what you can do or what you cannot do. What website is that?
Okay, I think I Googled telehealth and then it was very simply put, like alphabetically, Alabama. And it's simple to read, right? They just take out the quotations from the legal aspects, whether the prerequisites, all listed there for all the states.
That
Right.
could be a great resource. I take it upon myself that in next newsletter we'll address it. Get a proper,
I look and
right,
see, because I was
investigate
looking
it.
at pictures.
I can tell you that when I practice in North Dakota, our century code is very, very vague. And it doesn't specify where I have to be at all. It just says patient needs to be in the state. It doesn't say anything. about the
Yeah.
patient or the
That's
provider.
exactly what Dr. Purana was saying that.
And I think our board of nursing, I haven't looked to see the medical board, what it states. The board of nursing says, just refer to North Dakota Century Code. And it's very big.
So this is about North Dakota that it doesn't say explicitly what you should do. So at least
No,
it does not
it's-
prohibit you.
It's very vague. It's allowed, but yeah, it doesn't say.
As long as it doesn't explicitly say, just a comfort level.
If you have, I'm coming, HIPAA compliant telephones, I didn't think about that, but recently, because I'm thinking, okay, I don't know if all the telephones here in the US are HIPAA compliant. Then I'm calling from one place that I don't think we don't have HIPAA laws. Do you know anything about our phones should HIPAA compliant? I have no idea.
So the question was about HIPAA compliant phones.
Yes.
So one note of caution we all have to think about is telehealth has always been there for X number of years. Unfortunately, CMS had a lot of strict regulations about who's eligible for telehealth and how much the providers will pay. During COVID, that's when the situation changed, when we realized, when CMS realized that the only way to provide care was remotely. So they relaxed all the requirements on telehealth, including paying providers on par for seeing the same as I've seen in the clinic as well, right? Now, as of now, what I've read is that even though we've passed COVID, the requirements and the regulations that were in place are going to be valid until the end of this year. And that requirements specify not only the location, for example, in the previous life, which is before COVID, the requirement was that the patient should not have access to certain facilities or even the providers a minimum of 30 or 60 miles. Only then a provider can really do a telehealth with them, right? And so I'm not sure to what level they will revert back. I know a lot of states have realized that telehealth has been a great boon, and not just because of COVID, but after the fact, there's a lot of follow-ups, especially the psychiatric calls or any mental health calls made a lot. So there's every state and every association has been working hard to keep certain flexibilities in place. Now, I don't know how much the Congress will enact and enable, but you all have to be careful about looking at that, keeping an eye on what the regulations are, and making sure that you are not. We already have payers, for example, they have stopped paying us at the same level unless we do a video call. In the past, whether it's audio or video, they used to pay all of it, but now we have to be very cautious that, okay, if I'm really doing an audio call, they have a separate CPT code, a separate modifier, and it's less than like 50% of what they used to pay. So changes are already there. Just don't imagine or assume that you'll be paid as you were before. There are some obesity practitioners I know who are still doing 2% telehealth, but if they're doing a cash-based practice, no issues. They can continue to do it because there's nothing to do with payers. But if you are doing an insurance-based telehealth practice, be wary and be aware of all the changes that are coming and what will be permanent, what will be different. You don't want to be surprised that suddenly your revenue drop because the reimbursement are going to be impacted. Okay?
Sachin, can you speak to even like there's multiple ways for ancillary revenue, like CCM. Is there have to be an interval between the patient seeing? So not only where they are seen, how they are seen, what has been the length of time has expired that you have seen them last, right, that you can do certain things, right, given the regulation around that, right?
Yeah. So there were not much of regulations around that have changed. So since we do primary care and diabetes and obesity, a lot of the common services that we bill to insurance have always been there. They've actually added new services. For example, because of COVID, remote patient monitoring really got a lot more boost for all good reasons, right? And luckily, most of those actually have stayed on. In fact, CMS even added new CPT codes because they really see the value in that. So remote patient monitoring is a great example, an ancillary revenue. Whether you're doing obesity or primary care, they still can add a lot of value. The thing you have to remember is remote patient monitoring gets reimbursed at the same rate whether you have one device or 5 devices. So right now we're using a blood pressure cuff as well as a weighing scale and a glucometer. But what it means is that it allows you to equip your patient at home with these devices, and we set it up so that it's transmitting the data in real time to the physician's portal that is set up by the remote patient monitoring company, right? And that gives you an opportunity to keep an eye on where the patients are, and it has a system. The one we use actually, FusionCare, provides us alerts based on certain thresholds we set up for that patient. For an obesity practice, you can imagine how great that would be, because you not have to wait for 40 days for a patient to come back and tell you, oh, I lost 10 pounds. Right? You're able to progressively see how the patient is doing. Right? So typically in an RPM situation like this, they require you to bill once a month, and there are certain CPT codes that are allowed. Right now, we're able to get anywhere from $60 to $100 per patient with this setup for RPM, and the physician isn't spending a whole lot of time. The requirements are that you should have a care coordinator or even a medical assistant who's monitoring those, and you're able to see at least 16 days of data from the patients to build that code. So that's the RPM part. The other service is called chronic care management service. That's been there for a long time as well for Medicare patients. And what it is it's allowing the providers to stay in touch with the patients in between appointments. Because we kind of lose patients, especially Medicare patients or older patients. And because of the age they are in, the chronic conditions they have, it's possible that things can go bad really soon if some condition worsens. And they're encouraging the providers to use this service and get some additional revenue by staying in touch with the patients. This service allows you, from your practice point of view, or even you can outsource it to another trusted team that can stay in touch with the patient. The requirement is that you have to spend 20 minutes of time in the course of 1 month, and make sure that you're documenting what you have synced up the patient with. How are you doing? You need an appointment with the physician. You need a follow-up. You need refills. Oh, looks like you went to a hospital recently. How are you doing? Looks like the provider asked you to do the these interventions. How are you doing with that? Just keep in touch with that. And if there's an urgent situation that you're communicating back to the provider that, hey, he needs an immediate appointment. And that's really the care coordination part of it. And for doing that for 20 minutes a minimum, Medicare will pay you around $55 or $60. The good news is patients unfortunately have more chronic conditions. An average American who's over 65 to 70 has 3 to 4 chronic conditions. So if you spend more time, CMS is actually paying you more than that. So it's a great opportunity for providers to stay in touch with the patients, and especially in between appointments. And the minimum requirement is a 30-day, and you can only bill once. And the other requirement is that only one provider can bill. So if you have a specialist like a cardiologist and you have a primary care physician, both of them cannot bill. So what we do typically is whenever we are offering that service to the patient, just let them know that if any other doctor offers to do this, just let them know you're already doing it, your PCP. That way you don't get a denial, the provider doesn't get all upset about it.
What is that service called?
It's called chronic care management. Medicare chronic care management.
And you have to be very careful. And anything we do in patient care is we really do what we say we are doing. So do it right, do it with conscientiousness, and have programs that actually will track that time. So have a technical capability that you are collecting the time at the same time. So you are documenting that, yes, I was online with this patient, or my digital navigators were talking to the patient and time is running. So if you were ever audited, because there's been a lot of fraud in that area. So if you could take out, vet the companies that do it for you, or like our solutions that are already integrated into your EHR, there's a timer running, and you'll see that the time, whatever time you're spending is being captured and done.
Yeah. Yeah. The best part of this solution that we have is every time your MA is on the patient's record, it starts tracking the time. And then every time you make a call, because the program allows us to make an audio call, even a FaceTime or a video call as well with the patient, and it tracks that time as well. And at the end of the month, there is a monthly checkup that they can go through and ask a few questions to the patient. You can document all the responses and create a care plan for you. And that's based on what the physician has already recommended to that patient. It actually then creates a file for your report that you can now attach to the EMR as well. So if any time, Medicare is very strict because we have a lot of companies who claim they can do the CCM service on your behalf. That's our experience for us as well. They take 50 to 60% of whatever revenue you make, but they may not be doing a diligent job of that. So when I call my patient, I said, did you get a call from this company? They said, well, they called, but they just said hello and took a conversation and they ended the call. So, and then they don't even have a care plan that I can look at. So it's important to either do it yourself with your team if you have a team, or go with a trusted provider that you can make sure verify that they actually can show you how they track the time, what kind of care coordinators they have, and you make sure you do spot checks on the care plans. Make sure that you actually are seeing them. Check with patients as well, because our patients love that service. And one of the best things is that a lot of these adult senior population are, as you go for 75, 80, our oldest patient is almost 89. And some of them live in, retirement communities by themselves, and they can't look forward to this care coordinator call because sometimes that's the only call they get. And it's okay. I think isolation is one of the biggest challenges for a senior population, and the depression and everything that comes with it, right? Part of this call is really engaging with them, making sure that they're good, they're feeling better, and if they have family visiting, they also share that. And when they come visit the physician at our office, they always tell them, oh, your care coordinator, Miss X, called us, and it was great chatting. And that connection keeps that alive because they're always representing our physician. They know that whatever message they give is actually coming back to us.
I think if there are no more questions, I'll just. Yes.
I have a question about insurance, but no practice. So, like, physicians want to open an independent practice, like solo practice, who obviously don't have the leverage of people who cheat, with like several providers, for rates, and let's say I'm in telehealth practice and have a few different state licenses. So are there some recommendations about like malpractice insurances that would be able to, you know?
Yeah, that's, also very state specific and the mode of delivery specific and whether you prescribe compounded medications, etc. And we are hoping to add that service to our, service that we'll do the credentialing and help you find the right malpractice, and it'll help to have more providers within that. But it varies all. I mean, I have heard really low amounts of insurance, like the premiums people pay versus phenomenal. Like if you talk to Leo, I mean, in Illinois, they were having a hard time even getting insurance. So that's all over the place. You'll have to very specifically deal with multiple providers, malpractice providers in each state and negotiate with them. But hopefully we'll come up with a better way to do it. There's no right answer. I cannot tell you how much you should pay for solo practice. Then they'll say whether you do telemedicine, whether you do it for 10% of the time or 40% of the time. You do these medications. Do you see them in person? So there are all kinds of variables that will play into that.
So before you opened your very first practice, this question is aimed for both of you. I don't know if you opened your very first practice together initially or separate. And it can be obesity medicine practice or a different practice. What do you wish you knew before you made that first mistake?
I think our backgrounds are quite different, and we have come together for I don't know, some divine reason to be together. But I'm a gastroenterologist. I'm a GI hospitalist, so I do inpatient medicine, and I'm obesity certified. And I've thought of having an obesity practice for my hospital and clinic system that we can implement in a sustainable way that doesn't cause provider burnout and also keeps the system solvent financially. And so I was looking from that angle, and then, bumped into him by serendipity. Our third co-founder was here. He's the CIO of a large healthcare system. And then we put all our heads together and said, all these services are so fragmented. So I cannot answer that question because I haven't made that mistake yet. Because we are creating a real full solution, and tech-wise we're almost there. Is that you can come in, sign up, the key, open the box, use what tools you want, and get money. And our, billing, credentialing, the two other new additions we want to do is how to get you on board into insurances and how do we get you malpractice. Because those are two other barriers right now, which are a little bit difficult to, solve, but a lot of activity in this space right now is cash pay, which keeps it simpler, but it will keep evolving. Our goal is to be able to solve it.
If you're doing all of that for the doctors that are interested in joining, what percentage, let's say, if somebody was solo and having to do all the credentialing and taking care of malpractice, what percentage do you charge?
We'll work with you.
So I do want to answer your question because I've been through that boat. I'm starting to practice 7 years ago with our physician. And I can tell you that everything that we are putting together in this, like I said, if Fusion Care, this entity was there 7 years ago, our life would have been much more easier. And just to give you some examples of the nightmares we had, right? It took 7 months just to open the practice, right? The challenges of understanding what kind of entity a provider should really create. There's different models and every state is different. Understanding how insurance payers really work and what kind of contracts we need to create. We had no negotiating power. You couldn't even ask the question, well, how do I get reimbursed? Oh, there's a standard appendix A, read that. That's all we get paid. 85% of Medicare, that's all the standard. There's no way they would negotiate with you, right? What EHR should I use? Because our physician was employed with companies which
used Epic and Next Gen. It's a completely different experience altogether. And we can't afford that. It's $20,000 license fee. So what do we look for? We evaluated several EHRs. The first EHR we picked, we thought was good enough because sales pitch and we went through this, but they only do demos, looking good on a demo. They never give you live access to it. So we started working. Within 2 months, we realized the workflows just didn't work for us. And within, I think, 4 months, we decided, let's stop. And we only had a handful of patients by then. Went back and we did one more round of evaluation. We picked another EHR, which is the last 6 years has been good for us. But if you think about that, and also, well, we can't afford to hire 3 or 4 staff members yet because we need to build out that. And insurances don't give you patients in your hand, right? It has to come up word of mouth. Now it's a catch-22. First, I need patients, right? So we've had days when we're just kind of waiting for somebody to walk in, paying $200 per month leads, other utilities and stuff. So all of those challenges are very common on every practice, right? Now we have, I've seen practitioners who started telehealth at home with no investment, and they're happy with it, right? That wasn't possible then before. But what we are saying with this new entity that we are FusionCare is based on all of our experiences, our personal experience, as well as we've spoken with folks. And we are trying to provide you that obesity in a box kind of a solution where we are trying to find all of those services that you need just bare bones to start with. We will get you the patients. We will have a credentialing team that gets you registered, credentialed Medicare and the 2 local payers. And if you want to do a cash-based practice, we will partner up with a payer like a Stripe or a Square that will help you set it up for you. And we can even set up a website, a simple website, one pager. We'll start advertising for you locally in the community. So on day 1, when you open, even before that, hopefully you start seeing emails coming in from patients interested in talking to you. And I wish I had this service 7 years ago, but I learned from that, and what we're trying to do is really bring that service to all of the independent practitioners. Yeah, because I think the risk is, in my mind, the risk is threefold. One, either we'll keep working for direct-to-consumer platforms for obesity care at a very discounted rate. 2, this will shift to primary care, which in my opinion will be the last nail in that coffin, because dealing with GLPs and side effects and trying to meet expectations, right? And 3, we'll build another primary care kind of solution for obesity, because again, it's an office-based consultative practice. So if we did not somehow keep the independent practitioners independent, financially solvent, and do evidence-based medicine, this is exactly the line it will go as primary care is going on. Great. I hope you enjoyed, and it was a learning conversation for you.
So this is kind of in the word question. I've never been in a job position before where I've ever felt like patients would necessarily want to follow me. But I'm currently in a small clinic with 2 bariatric surgeons. But I'm going to start telehealth, might evolve into an in-person. And so, do either of you have any experience leaving a current or previous position when you were starting your own thing and have patients say, or follow you, where are you going? How did you tell them that without crossing the line with your current?
So likely I have changed jobs 3 times in my life, and likely in your contract you no, or somewhere you have it written that you cannot solicit those patients to follow you. They belong to the system, not you.
Other than like a start date, here's what you're gonna pay.
Because it's a right to work state, I bet, so they can't have you sign that.
I don't
They
know. I
have,
think
they
they
can
just
fire
want
you
an
for any
experience.
reason, and they, you
Yeah.
do it for any reason,
Exactly.
and it doesn't matter.
So maybe that's why, I don't know.
That's a right to work
I kept
state.
looking, do I have not compete?
Yeah.
I don't
you
remember
probably
signing
don't.
one. I don't see that I have one.
Well, so two things.
But I
One
don't want
is,
my employer to sue me, you know,
I would,
but
They won't, they can't, because you're probably.
Or I would not actively solicit either. It's a gray zone.
it is a gray zone.
People want to follow you, they'll find you.
that's kind of what I.
Yeah.
And I've had people find me before, like on Facebook and LinkedIn, oh, where did you go? I'm like, I'm working at the jail right now, don't wanna come follow me.
So two things, right? One, the good news is, you know, we just had a non-compete waiver that was announced. I know it takes some time, we'll probably have more lawsuits around it. But the default assumption you should always have is that you should not solicit, especially in the healthcare industry. It's so easy for them. And that's our pastime. American pastime is filing lawsuits. For an independent, it's really a death knell. You don't want to even have one lawsuit.
Right.
For the bigger companies, it's no big deal. So let's start with that. The second part, and we've had that experience. Our physician has worked in this community for 20+ years. And the good news of that is, yes, you cannot go we didn't have to go and ask. They actually heard about us. We did advertise, obviously, in the local newspaper. That helped a lot. And being in a community like that, one thing that we did do was we went and talked to all the peer physicians that we worked with in the past, letting them know that, hey, we opened a practice. So whenever, and there are good relationships, right? It's always good to leave in good terms with wherever you are working, because they are the ones who will send you patients, especially if you are a specialist. They are happy to send you referrals, right?
But we're a bariatric medical clinic, so,
Okay.
but I see 2/3 of the medical weight loss. So if I leave and they would all follow me.
I think outcomes matter a lot, and if you've done it really well, they will follow you, find you wherever you are. And think about the marketing strategies, right? As simple as setting up a web page, as simple as creating your own Facebook page and announcing it. It's easy for you to be present in your community, and that's how they follow. But we still have patients coming to us, because Kaiser is a kind of insurance which obviously it's fully integrated, which means patients cannot come and see us unless they change their insurance. But I have had several patients come because of the physician that was the first job years ago, and they said, we know you can't see Kaiser patients, but I'm happy to pay you cash as a self-pay patient just for this diabetes treatment or obesity, because they're not happy with whatever care they're getting, specific to that condition. That's always possible. And if you have great outcomes, people already know that you do well, care well, they are willing to follow you in that regard. So,
And if you're focused on the post-bariatric patients, that's actually a great niche. Yeah. Because frequently these are what I say, orphan patients. Surgeons have done the surgery and patients gone to primary care. Primary cares go back for this, and as gastroenterologists, I end up seeing them for iron deficiency anemia. Okay? So a lot of those people are actually not getting very good care. And I know I actually one practice that does only cash pay for post-bariatric surgery. So I don't think this you like they will be happy that you do that.
In terms of soliciting patients, I understand that you cannot actively reach out to them and tell them what to do, but if they asking you, that's not soliciting, that's understanding.
So a good point. Yeah.
I did contact a lawyer who did a quick little complimentary visit with me, and I thought I'd formulate kind of a letter of, hey, I'm leaving, get his blessing, and then who's gonna pointedly ask legally, the patient asks me, maybe that's how they begin to work around. What can I say? I actually had a massage therapist who's telling about my work stress, only for her to turn around and say, oh, by the way, I'm leaving. And I said, oh, how funny, because we've been talking about this. And her solution was just out of respect for my current practice. I talk about it. However, if you leave me phone number, I leave, I want you to know where I'm at.
Multiple ways to.
Yeah, I just wanna.
We are here for any time you need us, but I don't want to hold anyone up from dinner or anything. I mean, we have tons of snacks and wine left, but don't feel bad if you have to leave or something. We can keep this conversation.
Yeah, we can stay in touch.
With it wine. All right. So we'll gather in the back and then we can keep this conversation.
Thank you.
Thank you. Thank you, everyone. Thanks for everybody who attended virtually.